you 22 years of tricks. And I'm basically going to tell you everything that I've learned in 22, 23 years that's not in your textbook. So hopefully it's high yield because there's this off-label stuff. And I think before we start, I think the important thing to know is that if you're looking for an evidence-based medicine talk, there's probably some talks over there that are worth your while. If you want EBM, just leave now, okay? I'm not going evidence, I'm going practical stuff, okay? The first pearl I'm gonna tell you is probably the most important pearl you're gonna get the whole talk. This blew my mind away, which was, I saw this old guy, and he came in and he said, you gotta take this Foley catheter out. I'm losing my mind. The urologist was closed. You gotta get this out. So what we do in Canada when this happens is we take out the Foley and we take some 75-year-old guy and we check his left ventricle by giving him 4 liters of fluid until he can pee. Either he goes into heart failure, in which case we refer to internal medicine, or he's able to urinate and he gets his catheter gone and all good. So how do you do a trial avoid? So I said to the nurse, just take out the catheter, give him lots of water and see if he pees. And Nassim, one of the nurses, said, that's not how we do it in urology. What we do is before we take out the Foley, we clamp it, we put 300 mils of water in, and then we take the Foley out. So essentially he has a full bladder, and you show him where the bathroom is, and his ED length of stay is now 60 seconds. He is not in heart failure, and his ED length of stay is either if in 3 minutes he can't pee, you put the catheter back in and you say you're not ready. To me, this was unbelievable that no one else had thought about this. This is so brilliant. So trial avoid, people don't have to pay for parking. They're out of here in 30 seconds. We're sticking with urology, and this is a fun one. And as a feminist, it's a bit problematic, but I don't know if any of you do this, but sexual expulsive therapy for renal calculi. So the evidence for stone passage is shit with alpha blockers like tamsulosin, but the evidence for ejaculation or intercourse in men, unfortunately only men, with a prostatic urethra that relaxes helps facilitate stone passage, and it is better than tamsulosin. This makes for an awkward discussion. We do use it in for 3 weeks' time, and I understand that I don't have kidney stones. I'm probably not feeling very amorous, but it's a fun discussion. 3 weeks, tamsulosin for the passage of renal colic. It's free. You don't have to pay for the drug, okay? So telling people to ejaculate or masturbate, enjoy, okay? So Toronto, when I grew up, it had the largest tower in the world. This is the CN Tower. This is I'm from. We no longer are the largest tower, but sometimes we have patients who come in sticking with the urologic problems who have towers that won't go down. So the ED management of priapism has always been something that I've struggled with because I don't want to stick needles in sensitive areas. I don't have the skills to aspirate or any of that stuff. And one of my amazing colleagues, Catherine Varner and Connie LeBlanc from Canada, they came up with this concept of lower limb exercise for priapism. So essentially you take a gentleman with priapism and you say, walk up and down the stairs. Now, you don't want to use this as a stress test where you kill the patient. So if someone has a tight coronary disease, don't put them through this exercise. But essentially you walk them up and down and it is miraculous. We're talking within minutes, the guy's going to be like, it's working. I really think it's working. So you will notice a difference within 5 minutes. They will detumulesce, and you can send that person home. And more importantly, you're not calling urology. And this is something patients can do at home if they run into problems with priapism. Okay, the last thing of urology, and then I'll move on, is I am not a POCUS person. I don't pretend to be an expert. It's very difficult to get ultrasounds at 3 in the morning. The wonderful thing is you don't have to be good at ultrasound to realize how easy it is to detect for testicular torsion. The wonderful thing is you have 2 of them side by side. If someone comes in with right testicular pain, you put the probe on, you press the Doppler button, one of the balls will have blue and red stuff. If the other one has nothing, they have no flow. It is that simple. And you call the surgeon and say, listen, I want to let you know I've done a bedside ultrasound. There's no flow to the testy. I think you need to go to the OR. If they demand an ultrasound or a formal ultrasound, that's their prerogative, but you have done your part. From the time where I asked locating to call the specialist, I have already done the ultrasound within 30 seconds, and I know the diagnosis. This is not difficult. I'm not telling you to send people home based on your skills, but I'm telling you to call consultants based on your skills. Okay, one more thing about balls, but different ones, is I want you all to do something for me right now. You all have 2 fingers. If they're not dirty, touch your eyeballs. And I want you to feel that the left and right feel the same, okay? These are the exact same. You have just done a tonopen, okay? And in emergency medicine, we routinely, and I'm sure in not just Canada, what you do is you pretend that the tonopen is lost or the tonopen is broken. Or you're like, I have no fucking idea how to use the tonopen, which is another problem. Get comfortable palpating globes in the setting of acute angle closure glaucoma. Before you can find the tonopen, you will feel and appreciate a big difference between the eyes. It is a simple maneuver. And then if you really don't know how to use the tonopen, and some of the new ones are even more complicated and scary, at least you can tell the ophthalmologist the tonopen's broken. But on palpation, I appreciate a tremendous difference. I'd really like you to see the patient, okay? Everyone has something in emergency medicine they hate. I hate shoving things in people's nostrils, okay? That's just me. And epistaxis is something that I find disgusting. I want in and out as quick as possible. And what I don't want to do is shove things in people's nose and torture them, because that is what you do. So this trick was given to me, which is the concept of taking a rectangle of foam, it's called gel foam, and something called Surgicel, which is a dissolvable prothrombotic agent. And I make a Surgicel burrito. So I wrap the gel foam in Surgicel and I shove it in the person's nose. It is soft, it is sweet, it is lovely. Patients are not hating you, and patients don't have to come back in 2 days to have it removed, so they don't have to pay for parking. It will dissolve on their own. There's no follow-up visit. The Surgicel burrito is what you should do. You should never shove in rhino rockets in people's nose unless you like to hurt people. That's up to you. Okay, Simon Carley, who just walked in, and I don't know if he's listening, but I saw him. This is one of my favorite pearls that Simon taught me, which is this concept of also shoving something in people's nostrils, which is NG tubes. We often don't do this, nurses do this, and we put it in people's nose, and hey, I told you this is not an EBM talk, but this is an EBM pearl. If you just take an NG tube and you try your best, there is a 47% chance you are successful. That's shit, right? If you put a NG tube in, but you put a nasopharyngeal airway on the right side, and then you put the NG tube through the nasopharyngeal airway as like a Seldinger guard wire technique, that improves your success from 47 to 83. So essentially that's a 36% absolute risk reduction, a number needed to treat of less than 3. You should never be putting NG tubes in blind. Put in a nasopharyngeal airway first and then the NG tube through it, and it's a great way of showing off to people in the department and wonderful for patients. I'm not an ultrasound guy. There's always people in the department that can find veins very easily. Sometimes you'll get a really tiny vein that's not great. And what I will do if the nurse says, look, I could only get a 22 in the hand, and they usually want you to do POCUS, but I'm not great at POCUS. What I will do is take a tourniquet, put it on the proximal forearm, and then ask the nurse to give 50 mils of saline through that small, crappy IV, and then watch the vein just dilate. Then you have set them up for success to get a proximal line in, and then you take off the tourniquet. So blow up the vasculature and get the vein. It's simple, or if you're good at POCUS, just do that. But if they already have the line and they can't get it bigger, you don't need the ultrasound machine, you just need fluid. Okay, clearly the coolest thing, the easiest thing we do, the best thing we do is the nursemaid's elbow, the pulled elbow, right? This is what emergency medicine, peds emerge is all about. And all I've been doing is supinate and flex, right? Supinate and flex, supinate and flex. That's how we learned. Supinate and flex is 69% successful. You know those ones where you're like, you keep doing it, you're torturing the kid's like, what the hell are you doing? And then you start to say, shit, I think the kid has a super condler. You know those ones? It's not that. It's because there is a better way of doing this. Instead of supinate and flex, hyperpronate. Remember, as Eminem says, you only got one shot, right? And then you lose the parents and the kid. When you have that pulled elbow, just go hyperpronate, 94%. 94, 69, 25%. Number needed to treat a 4. Never do supinate and flex. Hyperpronate right out the gate, okay? That's your pulled elbow, perfectly done. Okay, without a doubt, the most bravado you can do in orthopedics is putting back hips, whether they're native, whether they're prosthetic. There's no bigger clunk in emergency medicine than the hip. And what I will say about this is when the thought of asking someone to do the Alice maneuver when you're 1.95 meters and like 100 kilos is I'm not getting on top of anyone's bed. And I suggest none of you stand on people's beds. That's disgusting, right? So you stand on people's bed. Fortunately, you guys might or might not be familiar of the wonderful rum pilot from the Caribbean's Captain Morgan. Captain Morgan has taught more orthopedics than anyone, which is if you see the way Morgan is with his left knee, this is the way you reduce hips without the Alice maneuver. The Captain Morgan technique is you put your knee under the patient's popliteal fossa, and then what you do with your ankle, like this physician is doing, is you basically plantar flex. You could see she's supporting the ankle. She's got her knee in his fossa like a fulcrum, and then an assistant is holding down his pelvis. It's a simple up move like I'm doing with my leg, and you've got the biggest clunk in medicine without an occupational hazard of getting on top of a patient, which you should never do. Okay, this isn't that fun, but you know what? I just like basic pearls sometimes. You know, carpal tunnel, we see these non-specific wrist pain. Hey to the audience up there, I didn't see any of you. That's wonderful, the standing room. Oh, third deck, you got a terrible seat up there. So with carpal tunnel, you make them do all these stupid things like Tinnels, Phalens, right? Like, who does that? Like, I have no patience to talk to people, as you can see. Tinnels, Phalen, they're crap. There was a Japanese neurologist who basically observed that all of his patients, he would ask them the following questions. When you took the Tokyo subway to the office, how did your hand feel? And they would always complain about being numb. What he decided is the hand elevation test. So essentially, when I see someone with wrist pain, I don't even do the test. All I say is, put up your hand while I'm talking to you. And then, but in the 30 seconds I need to take a history, I say, is that numb? And they say, yeah. And I said, you have carpal tunnel. So the hand elevation test has eliminated Phalens and Tinnel. Don't do those. They take time and they're stupid. Nails. It's funny. I actually like nails a lot, and I published on this about 15 years ago. I had my wife, and she was a runner, and her nails would fall off. But typically the people whose nails fall off are like 70-year-old disgusting fungal big toes that are yellow and fibrotic. And we used to try to put needles into those nails to replant them. And I would break the needle driver repeatedly. I would never approximate it. And I was having dinner with one of my friends who's a plastic surgeon. And he was like, you're not still suturing nails, are you? And I was like, yeah, isn't that what we're supposed to do? He goes, no one does this in plastics. You just glue the nail back. So essentially, you can glue everything in the nail. You see in this case, the nail matrix is destroyed. Put some tissue adhesive. Replant the nail and put a strip of glue on it and send the person home. Do not suture nails in. The only thing with this is you have to tell patients that glue will stick to the dressing. So be mindful when you take the dressing off, because sometimes they'll pull the nail back off. So the replant of nails using a tissue adhesive, you should never suture back in. You obviously have to anesthetize with a metacarpal block or a digital block so that you can replant it. You just want it under the cuticle so the nail doesn't fuse. Okay, do any of you like to cook? Any people here cooks? Okay, are any of you afraid of like grating cheese on a mandolin? Yeah, like the scariest thing in culinary stuff, right? And this happened to my wife about 3 months ago. So you see these mandolin where they just take a divot off their finger, right? So the first thing you do is you go see the patient and you celebrate that you don't have to suture because there's nothing to do. So then you're like, fantastic, I don't have a student with me, I don't have to suture, I have one. These hurt like hell. So the first thing you're going to do is you're going to dip their finger in a mixture of lidocaine, epinephrine, and tetracaine. So you're getting vasoconstriction and topical anesthesia. That's going to be 5 minutes. You're going to take it out, and you're going to wrap a tourniquet in this, and then you're going to just use glue on top just to form a seal. This happened to my wife. She was grating carrots. She took the finger tip off, just the nail and just a divot. I wrapped something around her finger. We always have glue at home. Stopped. Otherwise, these never stop bleeding. They'll never stop bleeding. I mean, they've waited for 4 hours to see you, and they're still bleeding. So for mandolin injuries, don't put like a bulky tube dressing and tell them to come back, and every time they change the dressing, it rips. Just tourniquet, lead, and glue. Okay. This is cool. I don't know. I think it might have even been on the pit. Nair is a commercial product used to dissolve hair. Who here has seen hair tourniquet syndrome? Yeah, you'll see it, and if you're a pen person, you've seen it a lot. I went to a conference where someone taught me this pearl, and literally I saw an 18-month-old screaming, and the mom's like, there's a hair on the toe, and I couldn't get it off. So my first thoughts were like, try to burrow under the hair follicle and just pull it off. And then I had gone to this conference, so I was like, you know what? I said to the nurse, here's $10. Go buy some Nair, which is a dissolving, and we just put the cream on the hair, and it dissolved. I didn't have to pick at the skin of an 18-month-old screaming child. I just put the cream on the hair that was wrapped around, tourniquet gone, painless procedure. If you're not doing that, this is the way to do it. Okay, I like physical exam. Who here's had Botox? Sorry, that wasn't a real question. What I will say is we have a problem in Canada. I'm not sure this exists in Germany. I'm not sure it exists in Europe. But we have a whole bunch of people who use Botox. Okay, where are you going with this, Dave? You sound tangential. So what I will say is when you see someone with Bell's palsy, the first thing you do is you ask them to open your eyes and you look at the forehead. What are you going to do when someone can't open their face and they just look like this? They've been Botoxed, or they're in early Bell's and you can't figure it out. Well, the wonderful thing and the wonderful pearl here is I was sitting beside a neurology resident, and I had like a 26-year-old. She had not had Botox, but she was 26, and I was pretty sure she had Bell's, but I wasn't sure about the forehead. And I was like, there's no friggin' way she's had a stroke. I don't want to do an MRA. I don't want to do a CTA. I said to the neurologist, like, what do you do? For sure she's got Bell's. And she says to me, how do you examine cranial nerve 7? I'm not going to pick on you, don't worry. But she was picking on me, so I'm like, you know what? I got some residents with me. Why don't we give them the opportunity to see if they can answer? So everyone says, wrinkle the forehead. She said, David, do you know what else? I'm like, you know what? I don't want to steal their thunder. What else is cranial nerve 7? The reality is none of us had any clue. She said cranial nerve 7 is the anterior 2/3 of the tongue. So when you have a suspected Bell's, let's say it's on the left side, what you're going to do is you're going to put some sugar on the right anterior 2/3. Can you taste that? Give them some water, shrink it down, and then you're going to try the other side. On the affected side, they will not taste the sugar, and you have diagnosed a peripheral 7th nerve lesion, whether that's from Lyme disease, whether it's a Botox Bell's. This is, again, a great party trick, great way of showing off. You can use D50 if you don't have sugar from the nurse's lounge, but sugar for Bell's is an easy way of diagnosing a 7th nerve palsy that's peripheral when you don't have a forehead that's involved. Okay, you know what? I don't know what that weird thing is on my slide, but that's okay. Perfect. What I would say is I'm an extremely impatient person. That's why I'm a good emerge doc, and I like to get answers fast, okay? One of the patients came in and they were like, Dave, there's a high sugar, they look really sick, and we put them on the monitor, and what I noticed was the end tidal was super low. So my first thought is, man, this person's acidotic. You know, sometimes we see people with high sugars, like the nurse will say, sugar's 30, but they look like a peach, and you know they're not in DKA. You know they just need to adjust their oral hypoglycemics or start insulin. So this person was sick and, you know, had DKA, but then I started to have an idea, like, I wonder if the end tidal means anything. So I found this great paper that looked at patients with blood sugars greater than 26. So the person you might suspect has DKA. And what they said, if the end tidal on the monitor is greater than 35, instantaneously you've ruled out DKA. But if it's less than 21, you've 100% ruled in DKA, and if it's less than 26, it's 96% sensitive. So if you have someone with high sugar and they're on an N title, you will know if they have DKA within seconds. You don't even have to wait for the gas. Now, start your fluids. You're obviously going to have to wait for the potassium before you start your insulin therapy, but at least you know what's going on is they're acidotic, they have DKA, start filling the tank. I'm an impatient guy, I've already told you, which is you have a woman, she comes in, she's of childbearing age, she's hypotensive with abdominal pain. You ask her if she's pregnant and she says, I don't know, my periods are irregular, I have an IUD, or I don't know. And you need to find out if she's pregnant because you think that she's got a ruptured ectopic. You have two ways of traditionally doing this. You send off blood, and in an hour and a half you have the diagnosis. You put in a Foley, which sucks, and you get some urine and then you do a dipstick. The better way to do this is if you have urine cassettes for rapid betas in your department, when the nurses are taking blood, take a drop of blood and put it on the urine dipstick. And you will find out if she's pregnant in 60 seconds. Remember, this is a qualitative, not a quant, but that's all you need in a hypotensive shocking patient, so you can call obstetrics and saying, the FAST is positive, the woman is pregnant, 60 seconds later, we need her to get the hell out of the emergent, go to the OR. This is a good Rebel EM, Sal Razai, Pearl. I don't work in a trauma center. I don't know what zone 1, 2, and 3 are. I look it up in a book, but I do know that if someone's bleeding a lot, what I'm going to use is Foley catheters to put into tamponade any cavity that's bleeding. You, like a Bacri balloon or whatever you're using Foleys to blow up a space and tamponade off bleeding areas is a good way of dealing with things. The Osler again, the young physician starts life with 20 drugs for one disease. The old physician ends life with one drug for 20 diseases. I want to tell you some drug uses that you might not be using. Let's start with cefadroxil. You all have cefadroxil in your merge. You have in your country. You have no idea what it is. Cefadroxil is a first-generation cephalosporin. It is equivalent to cephalexin. You guys all use cephalexin with cellulitis. Someone has cellulitis. You give them cephalexin, right? Willie, you give them penicillin. And penicillin's dosed 3 times a day. Cephalexin is dosed 4 times a day. Has anyone ever taken a drug 4 times a day? Good luck, right? No one will take a drug 4 times a day. So if you have cefadroxil, which you may look it up, I bet you do, it's 1 gram once daily. If you're using cephalexin, it's essentially 1 gram BID instead of 500 QID. Don't write drugs that are QID unless you want patients not to use them properly. I would even say TID is a problem. BID at best for people is the best way to improve compliance. Anyone have kids? Anyone go get car sick? Anyone pregnant with morning sickness? If you're not using isopropyl alcohol wipes, we have a lot of women in our apartment who are pregnant and they're just going in the corner and they look like junkies. They're just sniffing the shit out of these pads, right? Because they don't want to take ondansetron because it's very sedating. But the evidence for isopropyl alcohol wipes is stronger than it is for 5-HT2 antagonists like ondansetron. So in my bag here, in case I got sick, I always have isopropyl wipes that my kids know on every ski trip to Whistler, they're always sniffing that shit on the way up so they don't puke. Always have isopropyl. There's no sedative side effects so the kids can go in the pool when you get to your destination. They're not tired. They're not puking. You can do it for patients as well if you don't have an eye line. Okay. Does anyone here have a special interest in treating patients with cannabinoid hyperemesis syndrome? You like that? There's nothing worse of the chief complaint of scromiting, which is screaming plus vomiting, right? It is the absolute worst. And it's a whole other lecture to try to understand why these people actually don't think it's the marijuana, because the marijuana is protective, but I'm not changing culture. What I am changing is giving them antipsychotics. So I am using haloperidol as a first line, 0.05 milligrams per kilo to use for cannabinoid hyperemesis. That is the way to do it. If you're concerned they've already had dimethylhydramine or ondansetron and the QT you're worried about, do an EKG before you give a third drug that's going to prolong, because these are the people, if they're on psych meds especially, who are going to get prolonged QTC. But that is the way to do it. Haloperidol or droperidol, whatever you have, is wonderful for cannabinoid hyperemesis. If you have med students working with you and you want to have them go see a patient to do a fecal disimpaction, that's always a great learning step for them. I think it's torture to take an 80-year-old and stick your finger in someone's bum. I always use gloves. And try to just take it out. I'm not using procedural sedation, but I am using viscous xylocaine. I don't know why we, with Foley's, use xylocaine, but with constipation we don't. So I will take an ampule of xylocaine, squeeze, turn it in, coat the rectal area, and then have the student do the disimpaction. That's the way to do it, and it's good for the students. That way they realize it's a patient-centered care, okay? I'm pretty cheap on opioids. What I would say is I do use a lot of ketamine for opiate-free departments. That's how I'm using it, 0.3 per kilo. We use this in our sickle cell population. We're using this in lots of population, our cancer patients. We use a lot of Special K for people with pain. We are a big neuro center. We do a lot of surgical management of trigeminal neuralgia. We have a gamma knife, and these patients, their life sucks. They've tried GABA, they've tried pregabalin, carbamazepine, nothing works. I'm telling you what works is phenytoin. Phenytoin, not at the seizure dose. You give someone 10 per kilo, like 700 milligrams of phenytoin. One of two things are going to happen. Either they're going to get dizzy, lightheaded, hypotensive, in which case you refer them to internal medicine, or they get completely better and they think you're God. Ideally, it's the last one. This works for everyone. It doesn't last forever, but they're already out of the emergency department. They think you're amazing before it comes back in 2 days. But phenytoin is fantastic. Gout, I think we're all not doing this enough for gout, which is the pill in the pocket. The AGREE trial, AGREE, looks at colchicine for gout. And the way you treat gout is you give them 1.2 milligrams. Someplace in Europe use 0.5. In Canada and the US, we use 0.6. 1.2 milligrams, and then an hour later, 0.6 milligrams. These are for your early presenters that come in within 12 hours. If they haven't had gout before, they might wait it out, but I send everyone home with a 6-pack of colchicine so they can do this at home. And the first time your big toe starts to hurt, take 2 pills, and an hour later, take 1. I think I have 2 more slides, and then Kendall's going to kick me out, and we'll take some questions. I work in the baseball stadium. We see a lot of people choking on hot dogs. I use a lot of nitroglycerin for esophageal foreign bodies. We don't use glucagon anymore. And then the other thing I will say about nitroglycerin is for the massive PE that you're thinking of lysine or an interventional therapy, I am nebulizing nitroglycerin in an inhaler to help pulmonary and venodilate. Okay, I'm going to leave you with a final thought. I'm going to stand up for this one because I think it's important, which is, do anyone here work with radiologists? Okay, anyone here a radiologist? Okay, then I'll tell you the story. So, if you have a difficult consultant, it's 3 in the morning, you need a CT for a dissection, there is no technologist, there is no, they need to call someone in, and you're running into a conflict and you have a problem, you're gonna memorize the following phrase. It's gonna change your life. If you like to take photos, this is the most important photo to take, which is you're having this discussion, it's going nowhere. And you're struggling, and you say the following thing to the person on the other end of the phone. I am sure you can understand the implications of both of us missing the diagnosis. You pause, you repeat. I am sure you can understand the implications of both of us missing this diagnosis. We need to do the CT now. Sure. Thank you so much for your time.
Is there any burning questions? This is amazing. Thank you, David. Any burning questions? 1 or 2? Great. Thank you. Oh, sorry.
When you were talking about the Untitled CO2, is that in awake patients, and is that in a nasal cannula, or is that with a rebreather mask, or intubated patients?
So I can't hear shit. So the question was about end tidal. The question was about end tidal. These are with nasal cannulas. So this is an awake person that you think is hyper like DKA. This is someone who's coming in. They maybe look crappy. You're just having the end tidal in their nose. So within seconds, it's going to show up on the monitor. You can rule in or rule out DKA. Yeah. Any more questions, or am I done? Never done. Thank you so much for your time.
Thank you so much. Let me now bring the next speaker, Dr. Jesus Daniel Lopez Tapia, talking about the Cerebral Symphony. I'm looking forward to that. Thank you.
Thank you very much. Do you hear me? Yes. Thank you very much. First, thank you for the invitation to this great event. For me, really is a honor. I live very, very far to here, but I am happy to hear with you. I am talking about a different topic of the last topic, but it's the same, could be the experience. What we catch the experience for the emergency medicine. This is the important part of our. Look at this. The emergency room is not an ideal environment for thinking. You know, what we have in the emergency room: high temperature, constant life-threatening risk, sensory overload, fatigue and emotional stress, decisions made with incomplete information, and we are not purely rational. We are very, very emotional. And we need combine the rational with the emotion to take the best decisions in the emergency room. Our brain in the emergency room makes decisions under suboptimal conditions, and yet excels it demanded for it. This is not a class of physiology or anatomic, but just to remember the limbic system and the neocortex system. What they do in our practice, the limbic system in the emergency room, this is serious. Act now. Don't make a mistake, but the advantage is speed, but the risk is impulsive. We need to mix this with the prefrontal cortex. In the emergency room, how works the prefrontal cortex? Let's consider options. Let's review the data. What I am overlooking, the advantage is accuracy, but the risk is vulnerability to stress. When we are under the stress, we are automatic. It's physiology. We are automatic when we are under the stress. We need a lot of tools to do the best with our patients, because we have two processes, the dual process model, the fast system and the slow system. The fast system is intuitive, emotional, and pattern-based, and the slow system is analytical, thoughtful, and consumes energy. Very dangerous if you let the limbic system dominate. Very dangerous. Why? Because if we let the limbic system dominate, the clinical consequences are diagnosis unshoring, premature closure, omission of alternative diagnosis, stress-related errors, and it's an example. It's anxiety because I already seen 3 today. When you have a heart attack and then heart attack and then heart attack, and the other pain in the chest, you say it's a heart attack. It's the risk with the emotional situation. The optimal integration is for the masters, for your teachers, is the experts' characteristics. They recognize patterns quickly, avoid impulsives, validate with analysis, and adjust decisions with the new information. This is very important. Always use emotion as a sign, not a comment. The emotions alerts, the cortex decides. Actions are taken quickly and precisely. You need to use both. The expert intuition, correct decision made in seconds, based previously learned patterns. Okay. And what do we do to achieve this? It's easy? Maybe no, but let me give you a simple example. What happens if right now a lot of people run outside the room and scream? What do you do? Maybe the same? Why the people is running outside the room? But if I tell you, in this moment, there is a performance, in any moment, many people will run outside the room. What do you do? Maybe keep. What was the difference? The information. We need to understand the emergency medicine. We need to know the emergency medicine. For the youngest, we need to love the emergency medicine. Isn't perfect the emergency medicine. First, focus in the emergency medicine. It's the specialty emergency medicine. If you have 100 patients and you want to know all about your 100 patients, it's impossible. Your specialty is 20 patients, 20%. First, focus. And on different other specialties, many times we don't have or we don't need the diagnosis to begin the treatment to the patients. It's a great difference. This is all the day. The disease manifestation, the probability of error. We are in the area with more risk to the error, to the mistakes. Is how can you avoid the mistake in this moment, because we don't have all the information or all the manifestation of the disease. Focus on the vital signs when you don't have all the information. Maybe the diagnosis could be later, but in this moment, I need to save my patients. This is very different. In the left side, for me, for you too, we take decisions in 3 or 4 seconds. Do you remember the opening ceremony? We take decisions in 3 or 4 seconds. In the other side, the right side, is a room with another specialty. Sometimes they take many days to take a diagnosis, many days. Everybody together with papers, with journals, 2-3 days, and then they decide the diagnosis. And us, 3 seconds. Do it with fear. You are emergency physician, you can be afraid. No, the fear is good. Thank you for the fear, we are here. Its main function is survival and protecting the integrity of the organism. Do it with fear, but the good fear, the good concept. Always empathy with the patients, with the colleagues, with the family. Everybody has a lot of emotions in that moment. You are the more rational people, the more rational person in this moment. You can fight with a family, with a patient or colleagues, because you need to understand all the people has many emotions, and you are the rational, and you understand the medicine. We need a lot of hours to talk about the practical strategies, but just to say some things. Short cognitive breaks, checklists, teamwork, algorithms in critical scenarios. Let me stop here. ACLS, BLS, ATLS is very important. Not because it's technical situation or technical mode of practice our medicine. It's because when we have a critical patients, as you can see, we don't have the rational 100%. We need tools. And in this moment, this kind of algorithms are very important to don't forget any part of the attention of our patients. Always seeking support of a second opinion, always. It's not weakness, it's neuroprotection. Always search support for more colleagues. And my conclusion is, in emergency medicine, decision making is not a purely logical process, but a dynamic interplay between cognitive and emotional systems. It's not about choosing between thinking or feeling. Emotion is inevitable. Stress alters reasoning. Thinking well is a skill that can be trained. And is the last one. Thank you very much.
We'll take one question. I'm just testing the mic. Is it working okay? Yeah, good. Any questions? All right. Thank you very much. Really appreciate it, Jesus.
Thank you.
All right. It's my pleasure to invite my Canadian colleague also, Mohindra. He'll be giving us the last presentation for the day. Thank you, Mohit.
Thanks, Kendall. All right, so my name is Rohit Mohindra. I'm an emergency physician from Toronto, Canada. I work at North York General and the Schwartz-Reisman Emergency Medicine Institute. I promise I'm not going to shoot rubber bullets at you today. I'm not going to tell you where to stick fingers that are bleeding, but I am going to help you with something that I think will help to change your practice. If not today, definitely very soon. So I have no disclosures to make. So the things that I want you to get out of this presentation today, I want you to understand that AI is accessible in most emergency departments, and it's achievable if you start small. I'm going to give you some examples of things you can use that are AI-based or AI-driven that could change your practice, and we'll discuss some barriers and, most importantly, solutions to make sure the AI is working properly in your practice. So hands up if you're curious about AI. You've never tried it, but you want to, you're just curious about it. Hands up if you're using it maybe as a scribe or for other things, and hands up if you're using it as an integrated part of your care in terms of your EMR. Good. Okay, so this talk is for everybody. I'm hoping that there's going to be something for all of you. And most importantly, I'm going to give you some tools to make it so you can try this soon in your practice. So you first need a problem, and I think the problem I'm starting with is a common one, charting. We spend a lot of time doing it, up to 40% of the time. It's repetitive. Often we say the same things about the same patients. We do have to do it for each and every patient. And if you're using an EMR, it probably means you're spending more time with the computer than you are with your patient. You probably have to do clicks to order things. There's clinical decision support saying, did you know this patient was allergic to penicillin? Yes, I know. I'm still going to order ceftriaxone. These are the kinds of things that we run into. And so as a result, I think this is one of the many things that's building on top of our practices that makes it hard for us to be engaged when we're in our shift. And so an AI scribe might be something that you can use on your next shift. So what do you need to use an AI scribe? At very least, you need a computer with a microphone and some internet. That's the first thing you need. The second thing you need is probably to talk to somebody who works in a pay grade above you. Start talking to the people in your IT department, in your legal or privacy department, in your hospital operations department. You have to understand how these things work. They take the recording, they send it off to a computer somewhere, they do this processing, and they send you back a really nice formatted note. But patients haven't consented to this yet. And so you need to figure out with your hospital and hopefully with a patient experience partner or somebody who's willing to talk to you from a patient perspective, how are we going to make this work? Are we comfortable with the risks they're taking? I can't answer for you if it's going to be something that your department or organization is going to say yes to, but if you don't ask, you won't know. And if you can't use it, you can still use it for other things. They're very good at generating things like patient-centered, patient-friendly discharge instructions, and they can do it in many languages. Or you can even use it for administrative tasks. So asking it to book, you can say like, can you tell me a list of when the times are of the next patient for a follow-up appointment for a clinic. So you can put that public information in, and it can help to do it for you. It can fill out consults. So if you're filling out PDFs for consults for external services, you can upload the PDFs and just put the information and can fill those out for you. I think the problem with privacy and data transfer is going to go away in the next few years. If you are using an EMR, it's probably already stored on an external cloud somewhere. And so institutions are starting to realize that this is how data flow works, and this likely will become a more accepted practice. Now, the next question you might have is, well, what about ChatGPT? Why can't ChatGPT do all this for you? And the question is, yes, of course it can do it, but the problem with these kinds of apps is that they take the data and they use it to retrain their own algorithms. And that's not your information, that's your patient's information. And they likely have not consented to giving information about their past medical history, their social and personal history, medications, and medical problem. So this is not the place where you should be sending your recordings to get your transcripts done. However, there are ways to use it safely. Don't give it a question like, what should I do with this 24-year-old woman who's postpartum and has chest pain and has a heart rate of 120 and here's her ECG? That probably is going to violate a privacy rule in your institution or where you live. But you can ask it, I have a patient who's postpartum and has chest pain and is tachycardic. What are the ECG findings I should be looking for? So use it in a way to help challenge your thinking, to prompt your thinking, but don't use it as a way to do your thinking for you. The other problem you may come into is the seasonal surge around flu season. So hands up if this is an issue where you practice, where you get a big seasonal surge. Yeah, it happens in Canada. It's cold, people get sick, and from December to March, we're pretty much just dealing with seasonal illnesses. The problem we run into is our hospital is organized into sort of a diagnosis zone. So if you're coming in with respiratory symptoms, you are probably going to be set to this zone. And that zone fills up pretty quickly, whereas the rest of the hospital is kind of sitting around waiting and not doing very much. And so what our department used to do is the triage nurse or the department leadership, like the chief of emergency department, would actually start putting notes on the EMR, say like, hey, move this patient to this stretcher or see these 5 patients in this stretcher. And then if a sicker patient comes in, we can take that stretcher back. But why don't we use it while we're waiting for those sicker patients to come in? And so where AI is good at is these kind of manual, repetitive tasks. It's also very good at tasks that don't have a lot of high stakes. It doesn't really matter if you see that cough and cold patient in a chair, in a stretcher, in the appropriate respiratory zone. You just need to see them, make sure they're not really sick. You can start things, get medical directives like pain medication, chest x-rays, blood work started. And so what AI can do for you is if you use the right tool, so something that you do often that you can easily track. So since we use an EMR, we can track where our patients are at all time. It's repetitive, so it happens over and over again. And there's a pattern. This is where AI is going to be most successful. It doesn't do so well in those cases where you think about, is this a life-threatening illness, yes or no? There's not a lot of gray area there, and the stakes are much higher. But in terms of where somebody goes, it's going to do a lot better. Something else you can think about is maybe not for the sick patient who comes in medically unwell, but somebody coming in with a mental health crisis. So you and your mental health team probably do a very good job of de-escalating and supporting these patients. But for most of you, they go home, and that's about it. We don't really have a chance to intervene very much. We do know that other things like the social determinants of health, housing, addiction support, finances, access to clean water, to food, are all important things to support people who come in with mental health crisis. But it can be time-consuming to figure all that stuff out. Perhaps you're the only physician in your department. You don't have access to a social worker or a crisis nurse. So you and your nurse are spending time trying to figure out who is this patient and how can we help them get better and stay better. Sorry. So one way you can think about doing this is, well, let the machine learning, let the AI do a little bit of search around the patient. It can read through the chart and give you a sense, okay, this patient lives in this area or has these comorbidities or is reporting these issues. They've tried these community supports and it hasn't worked. So it can do a lot of that work for you. It's not going to tell you what to do, but you can go to your patient and make an informed decision with them about how else can we support you through your mental health crisis. And the most important thing when you're doing this is that you get the patients involved early. I want to say that the technology that you use, even though it's shiny and cool, is actually only about 20% of what you need to do. You need to be spending the rest of your time and energy building trust with your other providers, with your organization, and most importantly, with your patients. If you don't build trust, they're not gonna engage with these tools, and you're gonna be a step further back when a few years down the road you try to do something again. So it's worth taking the time, engaging with the people you need to engage with, and make sure you get it right the first time. So 3 things I think you can do if you're interested in trying AI in your practice or trying AI at another step. Identify a pain point, make sure it maps to AI strength, so something that's repetitive, data-rich, and has low stakes, and make sure you explore and engage all the different solutions and the right people to make it work. So thank you, and I'll take a few questions if there's time.
Thank you, Rohit. Any questions? Any budding AI questions or thoughts? Thank you.
How can you use the AI on support systems for psychiatric patients in case of the data issues?
Yeah, so it's certainly something that you have to have an established process of governance in your organization. The way that we use this tool in our hospital is it doesn't leave the hospital. We have our own internal computer where that data gets sent to. It's processed in our internal computer and then sent back to the physician as a report. Our EMR is cloud-based, so eventually I'm sure this will move to a cloud system, but that was the way that we were able to address the data privacy concerns.
Other questions? All right, seeing no hands. Thank you very much, Mohit. Really appreciate your time. Thank you all for attending the session. Thank you.